everybody, Mike Biamonte, FBI, School of Operational Medicine. How are we doing? Hope everybody's doing well. This is video 18, if you can believe that. We're going to start getting into neurology, as promised. Somebody who listened to the video last time said there was a volume issue, so I'm going to see, hopefully, I'm sure it's a user error on my part, and I'm doing something wrong, but I guess there's a discrepancy between the videos that I plug in and my volume of my voice, which typically I've been told there's no problem with my volume of voice, but maybe it's just the way it's being recorded. So if that's the case, I apologize. I'll see if I can tweak it. Let's see, admin stuff, nothing classified, nothing sensitive, no endorsements. I will shout out to NTTU, SWAT, our SWAT program for the FBI. SWAT pays my bills, so I have to make sure I give the shout out to SWAT. You can't bite the hand that feeds you, right? Let's see. I think that's the majority of it. Everybody's been really gracious in their comments. I'm getting a lot of good feedback, to say the least. Questions that have come up of, again, how long am I going to do this? As long as I can. Right now, everything's still kind of in a COVID flux. So we'll see. I'll keep chugging along, though. I appreciate all the input. I appreciate all the comments and suggestions, more specifically. So thank you for those. Let's see. We're going to talk about neurology. I get so excited about these things. I'm such a geek when it comes to A&P. Obviously, we're going to talk about A&P of neurology first. And we're going to skim over some of the pieces that we already covered in A&P and pharmacology. We hit on neurology, and even in patho, we touched on neurology. So we'll dive a little deeper into certain areas in this one. But again, we'll keep it understandable. Because neurology, like everything else, is just so unbelievably complicated and just fascinating as far as I'm concerned. So I went through a lot of different books and a lot of different materials that I have to try and put something together. And I found myself getting carried away. I wanted to talk about this and this, and I said, "Oh, stop! Bring it back in, and let's keep it simple." So that's going to be the job. Or my job is to keep it simple. Funny story though, I can't remember where I was. It was a class that we were doing, and we were in a cadaver lab, a gross anatomy lab at a medical school, and there was a tremendous wall. It was a whiteboard wall where the medical school students drew all 12 cranial nerves coming out of the brain stem and it tracked it. It was just unbelievable. To appreciate it, to see it, you have to appreciate it. It was beautiful. It's probably probably a word you wouldn't choose, but just so complicated. I remember standing there looking at it thinking, wow, this is unbelievable. And there was a FBI agent standing next to me. I looked over at him and I said, you know what this is? He looked at me and he rolled his eyes. He goes, oh yeah. He goes, I know what this is. And he didn't say it that way. He said it very humbly. And I said, really, you know what that is? He goes, yeah. He goes, and I can't remember exactly what he said. I'll paraphrase. Basically, he said, oh yeah, I've seen this about 1,000 times. He goes, I've probably dissected 1,000 brains. And I looked at him. This is an FBI agent. I said, what do you mean you've... He goes, oh, well, he goes, I have my PhD in neurology or neurobiology or neuroscience. I forgot exactly how he said it. I said, you have your what in what? He says, yeah, just as humble as the day is long. You never know who you're standing next to. Here's a guy who, and it was funny too, because I just reached out to him. I said, hey, you want to do a neurology video? He said, no. I can't say that I blame him. So when it comes to teaching neurology, there's, you really have to be comfortable in your skin, and I like this little skit.
The so-called brain stem consists of the midbrain, a rounded protrusion called the pons, and a stalk tapering downwards called the medulla oblongata, which passes out of the skull through the foramen magnum and becomes, of course, the spinal cord. Hearts and kidneys are tinker toys. I'm talking about the central nervous system.
Again, you can't go wrong with Young Frankenstein. Love it, love it, love it. All right, let's get into it. What we're going to do is we're going to kind of start off bigger and come down in anatomy. And in the next video, obviously, we'll get into disorders such as seizures, strokes, things of that nature. So let's go ahead first and put up this slide. Nervous system. We'll break it down again. You've seen this before, so I won't spend a great deal of time on it. But your central nervous system, right, as Gene Wilder alluded to, very complicated. The brain and spinal cord, which is where we're going to spend the vast majority of our time in this video. And everything outside of the brain and spinal cord is your peripheral nervous system. We talk about somatic versus autonomic branch. Somatic, easiest way to think about your somatic branch of your peripheral nervous system is your voluntary system. Your ability to wave your hand and speak and move voluntarily. That's all thanks to your somatic branch. Whereas your autonomic branch is more your unconscious acts, your autonomic nervous system, sympathetic, parasympathetic, fight or flight, feed and breed, alpha, beta, muscarinic, nicotinic. We beat these up pretty well as far as topics go in past videos. So I'm not going to get too crazy into that. Let's go ahead and just start looking at the brain. So I'll take this slide down and put this slide up. Let's break it down and, again, keep it simple. The brain in and of itself, as it sloshes around inside of our skull, it really doesn't slosh around. There isn't a whole lot of room in there. I don't care how smart you are. I don't care how dumb you are. There's only millimeters of space between your brain and the inside of your skull cap. And we'll talk a little bit more about that here later and how it's occupied with cerebral spinal fluid as a protecting agent. But here on the left-hand side, we see the cerebrum, and as we work our way down, the cerebellum and brainstem. Let's keep it simple. Cerebrum, big brain, big movements, big arm movements, big leg movements, sense of smell, touch, and we'll see a slide on this here in a little bit, vision. Cerebellum, small brain, if you want to look at it that way. This is your finer movements, if you will. And your brain stem, primitive brain, breathing, heart rate, blood vessel diameter, consciousness, these types of things. So as we sort of slide over to the right there, and we kind of cut the brain in half and look at it, your frontal lobe, your parietal lobe, your occipital lobe, temporal lobe is on the sides, right where your ears are essentially, in that area. So you look at your olfactory tract, your olfactory bulb, sense of smell. What I always found interesting is the long-term memory areas of your brain are in very close proximity to the olfactory area of your brain. This is why sometimes when you smell something, it brings you back to your childhood, or it brings you back to a place from years ago. Maybe fresh baked bread when you walk into a bakery brings you back to a bakery when you were a kid, or something. It's a memory trigger, which I think is pretty cool. As we work our way around your pons and your medulla oblongata, as young Frankenstein talked about, your pons is an interesting area. Your pons, again in Latin, pons means bridge, and it's sort of the gap or the bridge between big brain and brain stem. Interestingly enough, your second cranial nerve and your third cranial nerve pass through the pontine or the pons area of the brain. And we'll see a slide on that here in a little while. And if you equally compress both of these cranial nerves that control your pupil diameter, what you'll end up having is bilaterally constricted pupils. The pons area of your brain is also somewhat responsible for your ventilatory or your respiratory rate, and it's also somewhat responsible for your sleep-wake cycle. So in certain circumstances, if somebody has a bleed into the pons area of their brain, whether it be medical or traumatic in nature, they'll present just like an opioid overdose. Right? They'll have pinpoint pupils because that area of the brain is now compressing that cranial nerve uniformly. Uniformly? Is that the right way to say that? Yeah, we'll go with it. Why not? English wasn't always my thing. So it'll compress both of those cranial nerves. It'll affect their breathing ability, so they'll be breathing slowly and in a snorinous fashion, and they're going to be unconscious. So it looks just like a heroin overdose. And I've had 3 of those patients in my career. First one, I had no idea what it was. I was giving him Narcan until the cows came home, didn't touch it. Then when I got into the ER, they explained it to me. And then the two after that, years later, I came into the ER and I said, hey, this is how the patient presents. I gave them Narcan, didn't work. They're hypertensive, uncontrolled hypertensive history. Said it could be a pontine bleed. And of course, I got the yeah, whatever you say, Mike. I went back hours later and they said, how in the hell did you know they had a... I said, I've had a patient like that before. I should have really wowed him and said, oh yeah, the CAT scan in my ambulance showed me that. No. So that's just a quick down and dirty breakdown of big brain, little brain, brain stem. So let me pull a slide down for a second. And I like to use this example of an assessment technique, and I'll reinforce this in the next video. For me personally, if I walk up to somebody and they've sustained head trauma and I want to do a good, quick neuro exam, obviously my March, my ABCs, those are coming first. Those are my first exams that I'm going to do. But if I want to do a quick neuro exam, I'll look at the patient and say, hey, pal, come on, look at me. Show me 2 fingers on your right hand. And they'll kind of look at me, and if they do this, okay, great. That's it. It's all I need for a neuro exam right out of the gate. Why? What does that show me? It shows me that they've got big brain, right? The cerebrum is functioning because they actually have big arm movement. They have cognitive ability. They're listening to me. They know the difference between their left and right. And they also have fine motor movement. They can hold up 2 fingers. So that tells me that big brain, little brain, all right, cerebrum, cerebellum, is intact and undamaged for now. And it could deteriorate. But that's a quick down and dirty neuro exam for you, a little trick. What I always like to tell people, if any of you that are watching currently have infants at home, or you're a parent and you had infants years ago, you remember years ago when you put Cheerios out in front of an infant in their little tray, and they kind of, they're barely able to hold their head up, kind of like me on a Friday night, that sort of thing. You laid the Cheerios out in front of them, and all they did is they took one hand and they went, and they tried to eat the Cheerios. They had no coordination, no fine motor movement. They'd slap their hand down, try and force it into their face. That was it. But over the weeks to follow and months to follow, what did you find? Is that you put those Cheerios out on their tray, and little by little, one at a time, they pick it up and put it to their mouth. That fine motor skill. So what you were actually watching right in front of you was their central nervous system developing, which I think is pretty wild to see that right in front of us. So let me go ahead, pull this down, and put this slide up. This is just giving us, this means nothing in the grand scheme of things when we talk about EMS care, but just for an FYI, the different areas of the brain and what they do, right? From facial recognition to hearing, smell, speech. And when we get into strokes in the next video, if I did a word association and I said, all right, your patient presents with a stroke. Word association, most people are going to think the patient with the one-sided facial droop, the slurred speech, the dropped leg, the dropped arm, paralysis. That's your stereotypical stroke. Not necessarily. It all depends on how big the occlusion is and what area of the brain is affected. And we'll talk about cerebral circulation here in a second. But you may have a stroke where the only thing that's affected are the speech areas of the brain. And I've had patients like that, where they can move all 4 extremities, neurologically intact, cognitively, they know what's going on, they're tracking, but they can't speak. They have an inability to speak. That's just one type of stroke. You may have patients who all of a sudden have an inability to hear, blindness in one eye, you name it. It really runs the gamut. You may have patients that are unsteady on their feet, all right? They have an unsteady gait. And typically your older population, and the family will say, oh, Granny is getting unsteady on her feet, or Grandpa, yeah, he loses his balance a lot. And that may be the case, but Granny or Grandpa may also be having a stroke. It just depends on where it's happening. So these areas here that we see can be affected. And there's been documented cases of people reverting back to their native language. Maybe they grew up in Italy and they haven't spoken Italian for 40 years, and now they've had this stroke and they've reverted back to Italian. All kinds of wild things happen in the brain. The brain is just so fantastically complicated, and it's amazing. It really is. Pardon the pun, all the biggest brains in the world have been trying to study the brain for years, and we don't have a computer as highly technologically advanced as we are. We don't have a computer to even come close to touching what the brain can do. It really is pretty amazing. So let me go ahead and put this next slide up. Now, sort of working from the outside in. Oh dear, there go the dogs. Working from the outside in. There's much more protecting the brain than meets the eye. Even somebody like me who doesn't have a drop of hair. Hair is actually a very good cushion or buffer, if you will, from head trauma. So those of you who are fortunate to have full heads of hair, I am envious. But you have a bit more protection than I do against a blow to the head. So if we look here, we see skin, we see periosteum, and periosteum is just a covering of bone. We see the cranium itself, which is the bone. And then we see dura mater, arachnid matter, and pia mater. Dura mater in Latin is tough mother, and pia mater is little mother. Your dura mater is what separates the skull from the brain. And it is tough. For those of you who have ever participated in a gross anatomy lab, it is. It's very, very tough, thick. It's hard to describe. Your arachnid matter or your arachnid space is called that, arachnid being spider, because it has a labyrinth or a spider web-like network where cerebral spinal fluid flows. And your pia matter actually rests on top of the brain. I think of it as, again, my world is all about food, booze, sleep, and sex. So not necessarily in that order. But you take a head of cauliflower, you drench it in olive oil, and you wrap a piece of cellophane wrap around it very, very tightly. That's kind of your pia mater, if you will. Now take a piece of wax paper and put that over the pia mater. Well, that's your dura mater. Somewhere in between, if we put some olive oil in between, that's your arachnid space. Yeah, that's how I think about things. So let's go, well, let's stay on this slide for a second. So when we reference next class and when we get into trauma, we get into head trauma, we start talking about subdural bleeds. What we're talking about is a bleed, typically an arterial bleed, beneath the dura mater. So it's beneath the dura mater, but above the pia mater. So it's not inside the brain or intracerebral, if you will. Typically your subdural hematomas are venous, my bad, sorry. If the dog's running around, it got me all confused. Your epidural bleeds, so let me rephrase that, I apologize. Your epidural bleeds, the bleeds that are on top of the dura mater, between the skull and the dura mater itself, those tend to be arterial in nature. Those tend to be very, very fast bleeds. Those are the crippling bleeds. Usually you'll find a blow to the side of the head, the temporal lobe, blow to the side of the head, the temporal lobe area. That can generate a epidural bleed. Your subdural bleeds are slower in nature. Usually they're venous bleeds, a little slower. You can also hear them referred to as subarachnid bleeds, slow in nature, typically venous. Well, then you can have intracerebral bleeds, where it's a bleed inside the brain tissue itself. So let me pull this slide down, and we'll put this slide up. Now we'll talk a little bit about the blood supply to the brain. And this little diagram right here, now obviously you've got veins and arteries all throughout your brain. But this is sort of the hub, if you will. If you look, you have your cerebral arteries coming up from the bottom, your internal carotids coming in from the top, and where you see on the left, about halfway up, you see internal carotid artery. Those two side by side, left and right, come into that circle, that little gap right there. So you see your anterior cerebral artery, your anterior communicating artery, middle cerebral artery. That circle right there is actually called the circle of Willis. And it's a fantastic little feat of engineering, because what happens now is if you have a clot or rupture somewhere in that circle of Willis, which is your main pipeline to blood flow to the entire brain. If one area is damaged or blocked for some reason, well, blood can still get to just about every part of the brain because it's a circle. So as long as you just reroute the blood, you're going to continue to perfuse the brain, which is really pretty wild. So in the next video, we'll talk a little bit about small vessel occlusions versus large vessel occlusions and how they might present. But keep this in mind, just like when we talked in cardiology, when we go from aorta to artery to arterial to capillary, same rules apply here. They're just in the brain. We go from these large arteries, and they will scale down to arterioles, to capillaries, so on and so forth. So your circle of Willis is a really wild little area, little feat of engineering, if you will, to keep our blood flowing in our brain. So let me pull this slide down. All right. So all we've talked about right now is we've talked about blood flow in the brain. We've talked about different areas of the brain, how the brain is somewhat protected, central nervous system, peripheral nervous system. We haven't gotten too crazy into diseases because we'll do that in the next video. But anytime we have trauma to the brain or medical issues with the brain, there's always going to be something.
Put none of that stuff on my sled, Clark. You know that metal plate in my head? I had to have it replaced because every time Catherine revved up the microwave, I'd piss my pants and forget.
I had a partner years ago, who will remain nameless. He had a Kevlar plate in his head. Couldn't tell you why he had it. He wasn't a veteran. I don't know why it was there, some childhood thing. But if he bumped his head accidentally, he would go into a convulsion. Now, I know this isn't funny. I'm a cold-hearted bastard for laughing about it. But that's what would happen. And he'd snuggle up in the front of the ambulance. This is when we were in New York and we were sitting on a street corner. And if something happened and he would bump his head by accident, he'd start to convulse and piss himself. We went out of service. We had to change his pants. But I don't know. I laugh. I'm a cold-hearted bastard. What can I tell you? Okay. Let's continue on. Earlier I mentioned the 12 cranial nerves. We are not...
You missed the rest of that story.
What was that?
You missed the rest of that story.
I don't know what you're talking about. She says there's more to that story. There is, but I'm not going to deny everything, admit to nothing, and demand proof. Those are the words I live by. But we did talk about the 12 cranial nerves. That is a complicated animal. The PhD who happened to be standing next to me at the time, that's what he did. I'm sure he saw that in his sleep. At the paramedic level, we don't really need to know that many of them. Cranial nerves 2 and 3, maybe 10. 10 is your vagus nerve dealing with your parasympathetic nervous system. But let me go ahead and put this slide up. This is showing all 12 cranial nerves. And if you actually grab a hold of a human brain from somebody who's not using it, hopefully, you pop it out of their skull, you flip it over, you will see these nerves coming out of the brain stem, the base of the brain. And medical school students spend a nauseating amount of time diagramming and labeling and identifying all these different structures, and then they'll go over different exams. Even in dive medicine, you spend a great deal of time discussing your cranial nerve checks and how you're going to assess someone's cranial nerves. And we're not going to get crazy into that. In the EMS world, it's not what we do. But we have cranial nerves that control everything from sight to smell to vagus nerve to our ability to swallow, our trigeminal nerve. We'll talk about the trigeminal nerve in another video when we talk about Bell's palsy. We'll talk about an affliction of the virus attacking the trigeminal nerve or the fifth cranial nerve. So this is just a diagram of all of your cranial nerves. And one thing I want to point out is cranial nerve number 2, your optic nerve. And as you see here, remember we talked earlier about the pons area of the brain. It's this optic nerve, both sides of it, that will actually, and optic nerve and your oculomotor nerve 2 and 3, they'll come right through the pons area of the brain. So if we have that circumferential type of pressure on these nerves, it will affect your pupillary reaction and your pupillary diameter and your sleep-wake cycle and your consciousness and breathing and so on and so forth. But in head trauma, when we talk about blown pupils, so if we have a patient, as an example, with head trauma on the right side, a bleed on the right side of their brain, a lesion on the right side of their brain, which pupil is affected? And the truth is, it's going to be the right. The eyes are the windows to the brain. Your second, third cranial nerves, anything below that, they start to crisscross. So you'll have the contralateral side effect. So if we're having a right-sided bleed in our brain, we'll have right-sided pupillary effect, but we'll have left-sided facial droop, left arm effect, left leg effect. So the misconception is if we have a right-sided bleed, we're going to have left-sided pupillary changes. No, that's not the case. The eyes are the windows to the brain. What does that do for us in EMS? Nothing. Not a damn thing, because it doesn't matter to us what side someone's stroke is on. We're just concerned that they're having a stroke or a bleed or whatever the case may be. So those are your 12 cranial nerves. And there's all kinds of catchy ways out there for us to memorize OOO to blah, 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 blah. If you look it up online, you'll find all kinds of ways of remembering the cranial nerves. I had to remember it for paramedic class. I had to remember it for a number of other classes that I've taken, but then I've memory dumped them. I know a handful of them, and that's about it. So let's go ahead and pull this down. So what we're going to start to drill into now is the spinal cord. So we've gone from big brain, little brain, brain stem. Now we're going to work our way into the spinal cord itself, which is just wild. Wild stuff in the spinal cord. The thing that's funny, and it doesn't matter much to us, but I think it's interesting, is that the brain itself, on the outside of the brain, the cerebrum, we have our gray matter, and on the inside is the white matter. Well, as we transition down into the spinal cord, it reverses, and our white matter is on the outside, and the gray matter is on the inside. In the cerebrum, between your white matter and your gray matter, you have what are called your axons, your axonal connections. These are these microscopic wires or connectors that communicate between gray matter and white matter, thought processes, so on and so forth. What can end up happening sometimes in what we call shearing injuries, massive head trauma, if we have a jarring of the brain and the white matter and the gray matter sort of move independent of each other. I mean, they're not two separate things, but you have to try to think about it this way. What can happen is these axonal connections can break on a microscopic level, and you have DAI, diffuse axonal injury, and there are different levels to it. These are patients that are, let's say as an example, unconscious, unresponsive, but there's no visible brain trauma. On CAT scan, on MRI, it doesn't matter. There's nothing there for a doctor to look at and say, oh yeah, look, there's a bleed here. Oh yeah, there's damage here. They may have what's called a shearing injury or a DAI, diffuse axonal injury, and not see anything. These are the patients that will lay there unconscious, unresponsive for hours, days, weeks, months, and then all of a sudden, wake back up because the brain has figured out how to reroute the signals. In very, very lucky cases, in almost, if you want to use the word miracle cases, there are incidents where patients will be unconscious, unresponsive for weeks and months, and all of a sudden wake up. Nobody knows why, nobody knows how, it just happens. It's amazing stuff how the brain does what it does. But all that to say, the gray matter and the white matter kind of switch to where on the outside of the brain it's gray matter. Once we get down to the spinal cord, the inside ends up being gray. So let me go ahead and put this slide up. Here we see a cutaway of your spinal cord. And you see in the center, it talks about gray matter. On the outside, we have our white matter. Again, not important. What's important are your spinal nerves, your dorsal roots, your afferent and efferent signals. All right, let's go back to what we talked about originally. When we talk about sensory versus motor, afferent versus efferent pathways, if I touch something that's hot, right, the sensory receptors in my finger travel via afferent pathways, or these sensory pathways, via what's called the dorsal root ganglia. So it's these series of wires that travel to the back, essentially, or the posterior aspect of our spinal column, and they send the signal to the spinal column. Well, within the spinal column, we have a reflex. That signal never actually goes to the brain. That signal goes to the spinal column, and it tells the efferent, or the ventral root ganglia, more the front of the spinal column, tells these efferent pathways, hey, stupid, this is hot, you need to pull your hand back. And these efferent nerve pathways or these motor pathways will go to the arm, tell the muscles of the bicep to retract and pull back. So when we talk about afferent information, or the sensory information running along dorsal root ganglia, versus efferent or motor neurons running along the ventral root, these are two separate pathways, and a reflex actually occurs in the gray matter within the spinal cord. Now, we're not going to get into it, but there's all kinds of different syndromes, from Brown-Squarod syndrome to central cord syndrome, anterior cord syndrome, based on what part of the spinal cord is actually damaged will dictate how this patient presents. Everything down to their ability to sense temperature, hot and cold, is an indicator as to what kind of spinal cord trauma they may have. Wild stuff, it really is. So that's just a cutaway of your spinal cord when it comes to different sensorium. So is it possible, theoretically, for you to have damage to the spinal cord and it only affects, say, the afferent pathways? So is it possible that this patient now has an inability to feel but can move? Yes, and vice versa. There are patients who have the ability to feel everything but can't move. What we normally run into in a traumatic scenario is a patient who can neither move nor feel anything. It's usually what we end up finding. But there are those situations and cases where you can have that one or the other going on. Let me put this next slide up, and this is basically just reinforcing what I just said. So if we look at number 1, it talks about skin being sensory, going along that sensory neuron being more that dorsal root ganglia coming into the posterior aspect of the spinal cord. That gray matter is processing that signal and sending a reflex through your ventral root ganglia, right, or your efferent pathway, your motor pathway, to the skeletal muscle and telling it to pull back. So these are reflexes, and reflexes don't actually make it all the way to the brain, which is pretty cool in and of itself. So one other slide I'll show you here, talking about spinal cord anatomy, and the only reason I put this up, this just gives you a little bit more detail as to gray matter, white matter, the root ganglia, and a ganglia is just a cluster of nerve cells or neurons. That's really what a ganglia is. But what I want to point out to you here is even on the spinal cord, the dura matter, arachnid space, and pia matter that we described covering the brain are contiguous all the way down the spinal cord. So is it possible to have a subdural bleed in your spinal cord? And the answer is yes. How would we know that that's occurring pre-hospitally? We wouldn't. But just so you know, as far as terminology goes, hold on a second. I'm expecting a delivery from UPS. I don't know if it's him coming up the gate now, but we'll see. So we can have different bleeds in different areas when we talk about dural, being epidural or subdural. Could be big brain, could be down in the spinal column. Just depends. So I find that pretty interesting. Let me pull this slide down. Okay. So we're chipping away at it, and we're getting smaller now. We've gone from big brain down to spinal cord. but to look at someone's brain, that's really, I hate to say it this way, but I've said it 1,000 times, I'll say it 1,000 more. For you to go to a gross anatomy lab and actually see the brain, grab the brain, look at it, feel it, it's just such an impressive anatomy lesson to do that. I encourage you to do it any chance you get.
Good Lord. I ain't got nobody, and nobody cares for me. Igor, Frederick.
Yeah, that's one example of an anatomy lab. I just love Young Frankenstein. What can I tell you? I'm just a big idiot. All right. So going back to the brain, we talked about big brain, cerebrum, cerebellum, brainstem. Brainstem comes down, and it comes down out of that hole in the base of the skull that we've always talked about, the foramen magnum. So let me throw this slide up here. So we mentioned the foramen magnum. We've talked about the foramen magnum. I think I might have shown you a picture during one of the A&P videos. I'm not 100% sure, but that's your foramen magnum, the base of your skull, pretty big hole, and that's where your brain stem resides. So when we talk about bleeds of the brain, epidural bleeds, subdural bleeds, whatever type of bleeds, and remember, fluid is non-compressible. It has to follow the pathway of least resistance. So if we have a big brain bleed and it's squeezing and we have high pressure in there, well, that foramen magnum is the only place for that pressure to go. And it has to squeeze its way out past the brainstem. Well, if we're compressing the brainstem to squeeze out of there, what did we already say the brainstem was responsible for? Well, primitive functions. Heart rate, breathing, sleep-wake cycle, blood vessel diameter. So a lot of bad things are going to happen. So once we start to what's called herniate, and we have brain herniation squeezing down through the foramen magnum, our patient's going to present in a very stereotypical way, and we'll discuss that in the next video. I was watching Game of Thrones last night with my wife. We're power watching some of these series because, you know, just bored, and we start power watching things again. For those of you who've never seen Game of Thrones, if you're a big fan of nudity, sex, drinking, and violence, well, that's the perfect series for you. That's it in a nutshell. But one of the scenes is, huh? Well, you married me, so what does that say about you? She says, what does that say about me? Well, she likes the series too. Anyway, one of the scenes yesterday, one of these big, mean, nasty men was holding the bottom half of someone's skull in their hand, and they were drinking wine out of it. Well, that's a bunch of horse shit, right? Because if they're drinking wine out of the bottom of the skull, maybe the skull cap, yes, I can see that, but they're drinking out of the bottom of the skull. Well, the wine is going to pour down right out of the foramen magnum and a number of other holes, so that's just a bunch of crap. That's Hollywood, but I get off my soapbox about that one. Okay, well, let's see. That's the foramen magnum. Let's pull this slide down. Okay, I think we've covered the basics, if there is such a thing as basics in neurology, to say the least. We'll cut it a little short. There's a lot of information in this video, but I didn't go, believe it or not, too far down the rabbit hole. I really did just skim the surface. Again, I can only imagine in medical school the amount of detail they get into with some of these things. But we're not going to do that to you. I'm not going to do that to myself, quite frankly. But we'll call it quits here and just do a quick recap. We talked about big brain, big movement, all right? Cerebrum, big movement, a lot of senses, smell, balance, things of that nature, sight. Cerebellum, smaller brain, fine movement, your ability to do things like this, as an example, hold up 2 fingers. Brain stem, primitive functions, breathing, sleep-wake cycle, consciousness, heartbeat, blood vessel diameter, called deep brainstem activity. Spinal cord itself, right? The brain is surrounded by gray matter with white matter on the interior. As we work our way down into the spinal cord, we've got gray matter on the inside and white matter on the outside. We talked about ventral and dorsal root ganglia. We talked about efferent and afferent pathways as part of a reflex. We talked about the different layers, dura matter, arachnid space, pia matter, and how it's contiguous all the way down the spinal column. And we talked about the foramen magnum, where your spinal cord actually comes out. A little bit, we touched on the cranial nerves. Again, we're not going to get crazy into that because that's super, super complicated, and I am not about to try to study all that again and go over it, because at the end of the day, it doesn't matter to us pre-hospitally. So next video, we'll get into neurological conditions, diseases, signs and symptoms, assessment, and the minimum effect we have as far as treatments go, which is sad to say, but true. So we'll get into that. Okay, I think that's everything. Let's go ahead and code word. Code word for my FBI folk is pasta. And how I came up with that code word is, in my mind, remember, food, booze, sleep, and sex. Your spinal cord during a gross anatomy lab, to me, when you grab a hold of it, it reminds me of a big fat piece of al dente pasta. It's firm, but it's not super firm. It's kind of squishy, but rigid at the same time. I know, sick. So I thought pasta, that's a good code word. So pasta for video number 18. Okay, I think that's it. I hope the volume on this is good. If it's not, please let me know. Everybody have a great day. Everybody have a great weekend. Be safe, and we'll see you all soon. Take care.